Hello, my name's Will. I'm one of the ST5 registrars at Sunderland Hospital working in gastroenterology. This is just a short run through of the newly coming upper GI bleeding bundle in order just to orientate you and make it useful in clinical practice. Upper GI bleeding, the reason for a bundle is that it's very, very common, and also that the mortality hasn't shifted appreciably in the 2 decades that we've been studying it properly. In fact, increase in mortality is probably due somewhat to better recording rather than anything else. There have been numerous sets of guidelines, but in the 2015 NCPOD review, it generated quite a lot of concern about suboptimal care. And in fact actually decided that probably only about 44% of people got good care out of it. This bundle was born out of that and some work by a group of registrars down in the East Midlands in order to try and address those problems. It's been led by a variety of Royal Colleges and pulled together by John Morris, one of the Glasgow gastroenterology consultants. A pilot has been performed of this in Scotland, and then we're rolling it out into the northeast in the form of a region-wide quality improvement project. We've collected 4 weeks worth of data. This is a short piece of education to go with that, and then we're going to produce another study period there afterwards in order to hopefully see that we've made a difference. This is what the bundle looks like on paper. At Sunderland Hospital, it'll be based in the V6 Meditech system and will be a separate document and an add-in section for those in A&E, and will replace the existing Blatchford score document. It breaks down into 6 bits, all starting with R. The first is recognition. Patients coming in with upper GI bleed present with hematemesis melina and also occasionally coffee ground vomiting is a possibility, although remembering that coffee ground vomiting should probably be accompanied by other signs and symptoms in order to make it more certain that they've had an upper GI bleed. Just remember that also bright red blood coming from the bottom end can actually be an upper GI bleed as well, if there's particularly brisk gastric transit, and that obviously a raised urea and a dropping HB with that may actually show that. And the idea being that if you think somebody has an upper GI bleed, to place them nil by mouth immediately. Then in kind of the first hour after a recognition, it comes the resuscitation bit, an ABCDE approach as always, and inserting 2 large flow cannulas. We'd prefer green. Just the flow rate is so much better through them if somebody becomes acutely unwell. However, if you can't manage green because the person is old or particularly shut down, then the largest that can be managed. An urgent set of blood tests, including all the things that you need for bleeding and a cross-match, and the idea being that we should aim to transfuse them for an HB of between 7 and 10. Obviously, if somebody's having quite a lot of ischemic chest pain at a lower HB, then raising it higher would be necessary. But there's good evidence to demonstrate that a liberal transfusion strategy that's aiming above that actually worsens morbidity and mortality. Clearly, if somebody is at an HB of 75 and still profusely bleeding, then please do start transfusing them, but try and combine common sense with the idea of less blood than we are used to. Also, the idea is that they should have 2 bits of thought going into them. A varicose assessment: could this person be having a varicose bleed, i.e. are they or could they be cirrhotic? And a severity assessment. Talking a bit more about the severity assessment first, we're using the Blatchford score. A Blatchford score of 0 or 1 is a consideration for early discharge. 2 and above is admission, unless of course there are other features in the 0 and 1 that make you think that they need admission as well. the score will be calculated automatically on the on the bundle on the Meditech for you. Varicose, do they have cirrhosis or varices? Do they have the stigmata of chronic liver disease? Do they have a low albumin and low platelets combined, or an ultrasound showing previous cirrhosis? Treatment comes next. If they are varicose, then they need both terlipressin and antibiotics as per TREST protocol, and they also need a cirrhosis care bundle, which is also available on Meditech, in order to try and improve their chances of survival from a varicose bleed. If you suspect that this might be a varicose bleed, treat it as one. If we then put a scope down them and find that this isn't a varicose bleed, we can then stop the treatment. You're much more likely to do them harm by missing a varicose bleed than you are by over-treating one that isn't varicose. The minorly controversial bit here is that everybody should continue their low-dose aspirin as long as it has a reasonable indication. There's some excellent work demonstrating that stopping aspirin in this group increases their morbidity and mortality, partly from cardiovascular problems while they are bleeding. Obviously, they're under greater stress and more likely to have a cardiovascular event, and partly because we keep forgetting to restart it as they leave hospital and therefore deny them its long-term protection. All other kind of antiplatelet and antithrombotic medication, anticoagulants too, should be stopped. Of course, if you've got significant concerns about an individual patient, a mitral metallic valve or very recent PE or very recent stent, then it is worth liaising with the gastroenterologist and the interested party, typically the cardiologists, in order to try and think about that. All patients should be kind of referred to endoscopy following senior review and discussion, and thinking about that higher Blatchford scores should have endoscopy within 2 to 12 hours, and that also includes patients with ongoing bleeding, a high kind of shock index, or if you're thinking about this person needing not to have an interruption of their anticoagulation, and all other patients should receive an endoscopy within 24 hours of the presentation. Again, there's some really good evidence showing that if we scope these people too early, we also do them harm. So it's about adequately resuscitating the patient, having a sensible discussion with a senior doctor in your department, and then referring on to the gastroenterologists with a well patient in order that we can get the best effect with an endoscope. This bit then comes to the gastroenterologist handing back to whichever team is caring for the patient, that they should have a clear endoscopy report, which includes what's happened endoscopically, and what should happen next if they continue to bleed. Is that a relook endoscopy? Is that interventional radiology, or is that consideration of surgery? It should include notification about whether they want a PPI infusion, and it should make a clear plan for resumption of antiplatelet or anticoagulant medicine after the bleed has been controlled. That's it for this particular presentation. Please do get back in touch with myself or Simon Callum if you've got any points to raise. We feel that this bundle will be a really useful way of improving the care of the patients coming through Sunderland Hospital, and will be part of a national scheme rolling out in order to standardise care across the UK. Thank you very much.